All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So I hope that the internet is okay. This actually, the time change has brought us in a time zone where, or at a time where a lot of people are just turning on Netflix and so on. So we are kind of clashing with that. Okay, so today's discussion is about a study that is printed in JAMA in January, and that is about the risk of myocarditis in various age groups after the messenger RNA based vaccines, and that is Pfizer and Moderna. These are the vaccines that they discussed or they observed. What is interesting is, let me give you the punchline, and then we'll go through a lot of data as well. The punchline is this, that in younger males, lesser than 30 years of age, more than 12 and more, and lesser than 30. In younger males, after the second dose, the risk of myocarditis is 70 point something per million. This is 12 to 15 years of age. 70 point something per million doses, and the expected rate was 0.53 per million doses. So if you divide them, that almost is about 133 times more rate of myocarditis or risk of myocarditis compared to what was expected. So this is the basic summary. This is 12 to 15. Now, to go in detail of this discussion and to see the other age groups as well, I would like us to keep a few variables in our mind. Number one, what is the rate of myocarditis in general population, children's population, without COVID, without vaccine? That's one. Second, what is the rate of myocarditis in patients of COVID, younger patients of COVID? Thirdly, what is the rate of myocarditis in patients with vaccination who received this vaccine? That is what are the three variables to compare. Sadly, the data does not settle on any one area. And so we can look at these separately. For example, we can look at the expectation of myocarditis in COVID compared to baseline, and we can see separately expectation of myocarditis in vaccinated compared to baseline, but they are not comparable to each other because the baseline is calculated differently. So it almost sometimes make me mad that the organizations like CDC, FDA, they have not put these data together in a way that one can make the sense together. You have to hunt around. So now let's start looking at the data. Keep these things in your mind. And of course, welcome. So this is drbeen.com. There is a link in the description to the premium account for drbeen.com, really inexpensive. So sales pitch done. This is CDC. This is March 16, 2022. This is the death data in various age groups. What I would like you to keep in mind is look at this number, 5 to 18 years of age from 1/4/2020, January 4th, 2020, till now, 3/12/2022. So during the whole period of pandemic, 731 deaths total. This is not a percentage, this is not per million, this is the total deaths. What is missing in here is comorbidities. And you would see throughout the discussion today, in all studies, comorbidities are not even discussed. And I think that is what is really missing. Secondly, I believe that 5 to 18 years, there are a total of about 80 million children in the US in this age group. Okay, so then this is the study in question that we will go over. Here is some more data. That study is used here by CDC to provide some information. It is interesting that at the end of it all, they say, should I still get myself or my children vaccinated? And they say yes. So this is CDC for you. This is again the cases per 100,000. That's fine. This is an Israeli article about this study saying new study 133 times risk of myocarditis after COVID vaccine. And I saw another presenter saying that, hey, it is really not 133 times, it is 70 times or 80 times. So we'll look at the data to understand where this article is coming from. This is I just got my vaccine. US rollout expands to children aged 12 to 15. Why did I bring these links in here? The study that we would discuss today is from December 2020 till August 2021. And they have about 200 million, or actually 300 million, about 300 million doses of vaccines given to 200 million people. But in my opinion, a majority of those doses were actually given to folks at higher age because that is how we started. That is just my opinion. I may be wrong. So I have sent a note to the author of this study, Oster, Dr. Oster, and I have requested this clarification that the denominator that they used, the total vaccine count that they used for each age group, was that count stratified for that age group? For example, 12 to 15, if they were given 100,000 doses, did they count myocarditis cases out of 100,000? Or did they take all the 300 million doses and they use that in the denominator? So we'll have to get that clarification. Meanwhile, 12 to 15 started with the vaccination on, I believe here, you can see May 13. 16 to 17 had started on April 21. Then here is a link to the COVID-19 related myocarditis compared to the baseline expected myocarditis. This is an article by a doctor, good article, I like it. This is another article by AAP, which is American Academy of Pediatrics, where they talk about the risk of myocarditis with COVID-19. And if I can just very quickly read it, I have that in the presentation too, but just keep this in mind that they are saying under 16 years of age, the children's risk with COVID is 37 times higher than expected. Now, if I can add that in the vaccine data, you would see that the children's risk under 15, 12 to 15, is about 130 times higher than expected. The question in here, the trick question, is that the expected part, where did they and how did they calculate that? That is different from each other. And then the third one, this is an article by Children's Hospital of Philadelphia, and here they're talking about the myocarditis because of because of COVID versus myocarditis because of vaccination versus baseline. So they have done some work over here, and it is interesting to see. So these are the references. Now let's go to correct. So there are comments like children usually don't get myocarditis. That is correct, but there are a number of children who do get myocarditis as well. And John Snyder says, how many children died from vaccine-induced myocarditis? So there was, in this study, they said 0 children died of the vaccine-induced myocarditis. However, they said there were 2 deaths because of myocarditis. However, these are still being investigated. That is why they are not used or reported. And I'll show it to you. So I sent an email to the Dr. Oster asking that, hey, what was the result of those adjudications for myocarditis deaths in children? Or were they myocarditis or not? Or were they vaccine related or not? So this is the background. Now let's start our discussion. So today, because this is more data oriented, I thought instead of drawing, I'll just bring that data together. So this is the study, myocarditis case reported after mRNA vaccine. I have no disclosure. This is for your viewing pleasure. Silver Ridge, California. I did a plein air painting. This is that painting. So we are in the Omicron, probably BA2 now. This is a medical disclaimer. This is not a medical advice. It's not a suggestion to do something. Whatever you have to decide for medicine, talk with your doctor and then make a decision. This is more of an informational, educational discussion. Considerations. So before we look at this, the considerations are following. Expected number of cases were identified using myocarditis data from 2017 to 19. So when you hear about expected number of myocarditis, that data is pre-pandemic data, which is good. So it was not affected by the pandemic. Exact number of doses for each group is not used. In my opinion, the data that I saw, what they did was they stratified the vaccine data by vaccine type, Moderna or Pfizer, and then dose, 1 dose, 2 dose, and unknown dose. But I think in the data, they had not stratified by age to say 12 years of age, 100,000 vaccines doses given, or 17 years of age, 200,000 doses given. I think the overall doses were just accumulated per vaccine type and dose. The study's time is December 2020 to August 2021. And what they saw was that younger age males had the highest number of myocarditis cases. About 80 or more percent of the cases were in lesser than 30 years of age of males. Now, the data is collected from VAERS. VAERS, we all know, has a problem with the reporting. It could be underreported or even overreported. So the authors actually acknowledge that in the limitation, and they say, we know that VAERS could be underreported or overreported. Now, in this specific study's case, the myocarditis cases that were reported in VAERS were adjudicated, and majority of them were found to be legitimate cases. And so authors say, because majority were legitimate, that means there must be some more that were not reported. So this is underreported. If there were more not correct myocarditis, then it would have been leaning towards overreported. So it will be safe to assume, actually authors say it in their limitation, that this data is actually underreported. Actual data will be more than this. That would mean that the numbers that we would see are actually in reality more than this. Then the comorbidities are not present. There is no data to say diabetic children, children with cancers, children with other immunosuppressing diseases, and so on. There is no such data. Then there were 2 deaths that were in the, these were supposed to be myocarditis from vaccine. However, because these 2 deaths were still under investigation by the time the study was printed, these were not added to the report. Now consider this, that 16 to 17 years of age became eligible for vaccination in April 2021. 12 to 15 became eligible on May 13. Why am I talking about it? They are talking about 300 million doses. As I said before, if these are the total denominators, total in the denominator, then we may have a numerical problem there. Now, study period itself goes from 2020 December to August, which includes, I think, majority of the doses going to the higher age group and then to children. Now, general note for this discussion, over here, I'm not going to offer you an opinion to say you should have the vaccine or you should not have a vaccine. That is a discussion between you and your doctor and your child's doctor, if that is a case. Now, here is the first interesting contextual graph. This is from the study itself. So if you see here in this graph, on this left side, and it is not supposed to be red, you can go to the study and see it. I want to show you something as a bigger picture. And that is, if you see here, the first group or first chart is for BioNTech, that is Pfizer. And if you see here, it stops at 40 years of age. Why? Because they say underneath that after 40, The maximum number of myocarditis cases per million were 8. It did not go above 8. So they just did not even discuss them because there are, let's say, another 4, 5, 6 slots multiplied with 8. That is the total number of myocarditis. So majority were below 40. That is why they only went up to 40. My thought would have been that the total number of doses that they used should have been up till 40, and for each age group, the doses for that age group should have been used. I think that was not done. So the total doses included all age groups. However, the data here they felt was more interesting up till 40. And here, if you see, younger age group has higher incidence of myocarditis or higher risk of myocarditis. And the light versus dark blue is 1-dose vaccine, light blue, 2-dose vaccine, dark blue. Now, this is BioNTech on the left side. Right side is Moderna. Moderna started from 18 onwards. That is why they have lesser data for the younger age. So this is the context. I talked about this article. So in this article, the good doctor here, he wrote the following. He said that in a study, that study is actually on CDC. In a study, they saw, just read the red part, although the overall risk was low, the data translated to a risk of myocarditis that is more than 30 times higher among COVID-19 patients. So that is the takeaway for COVID-19 in children causing myocarditis that was 30 times higher than the baseline. One. Then here there are two separate articles. One article that is in the AAP, which I showed you before, the risk of myocarditis for children under 16 years is 37 times higher. So the previous article said 30 times, this article said 37 times. Then if you see the next one, there they are saying that the risk is actually different from the vaccinated. And how are they discussing that? What they're saying is the following. They're saying if you take 100,000 children and you have them vaccinated, then out of those 100,000 of this age children, they think that the study shows 4 to 7 cases. So if I extrapolate that to say 1 million will mean 40 to 70. So that almost looks like the age range of 12 to 16, 17. Then they say if you do not vaccinate this group of children and let them spend time in community, within 3 months, out of this 100,000 group, 5,500 will develop infection. And then out of those 5,500, they think that there will be about 50 hospitalizations, including myocarditis. So again, the data falls apart here once more. Those hospitalizations, are they myocarditis or not? Because that is a discussion. Having vaccination and its effect is a different discussion. Okay, so this is the context. Now, the corresponding author for this study is Dr. Matthew E. Oster. The objective for the study now that we're talking about, is to describe the reports of myocarditis and the reporting rates after mRNA-based vaccines in the US. Their conclusion is the following. This is the most important part. Their conclusion is, based on the passive surveillance, that is VAERS, the risk of myocarditis after receiving messenger RNA-based vaccines, COVID vaccines, was increased across multiple age and sex strata and was highest after the second vaccination dose in adolescent males and young men. This risk should be considered in the context of the benefits for the vaccination. This is their conclusion. Now, a quick profile for the study. 192 million individuals above the age of 12. 354 million doses administered. VAERS data not adjusted for underreporting or overreporting. This whatever is the data is the data. And they say, this is the excerpt from the article, therefore the actual rates of myocarditis per million doses of vaccine are likely higher than estimated. This is in the study. So the numbers that you're going to see, as much as they look higher than expected, 130 times higher than expected, they are still underreported. So then they say, as such, the reports of myocarditis to VAERS may be incomplete, and the quality of the information reported is variable. Missing data for sex, vaccination dose number, race, ethnicity were not uncommon in the reports received. History of prior SARS-CoV-2 infection was also not known. Because of this, I've seen many presenters kind of using this and running with this and kind of taking this as an important study to say there is an issue going on. I think that the data has a lot of gaps in it. So what are the events? So once again, 192 million people, 354 million vaccine doses, 1,991 reported cases of myocarditis. Now, if we go with the number that above 40, for each age group, there were hardly more than 8. So if we say 40 to 50, 50 to 60, 60 to 70, 70 to 80, 80 to 90, 90 to 100, 6. That is another, what, 48 cases? So this whole majority of the cases here are under 40. And you would see that 82% of these were under 30 in men. Confirmed cases were 1,626, meaning they're adjudicated, they verified if these were myocarditis, and they turned out to be myocarditis. Now, this middle column is interesting. Age. Median age was 21 years. And interquartile range was 16 to 31. That means 50% of the cases were in the age range of 16 to 31. 50% of the cases were in 16 to 31. Time to symptom onset, that you got first vaccine or second vaccine, how quickly the myocarditis started. So the time median was 2, interquartile range was 1 to 3. That is 50% of the cases of myocarditis started within 1 to 3 days. Males were 82% involved, and most cases after the second dose. Now, here is a summary data. This is just an eye chart. I wanted to put that in front of us. Now I'm going to actually go over this data. This is the time to vaccine and the symptoms. Here is the data. So this is the crux of the matter here. So the way to look at it is, let's look at the rightmost column first. The rightmost column says expected cases of myocarditis in a 7-day risk interval per million doses. And so here, if you see, let's look at the very first row. It says 0.53 per million cases. That is expected. And this is the age group 12 to 15 males. And after the second dose, the actual found myocarditis was 70.73 per million. So if you divide 70.73 over 0.53, that is about 133 times higher than expected. Now, keep in mind that this is actually an underreported data, so actual numbers should actually be higher. If you look at 16 to 17 years of age, expected cases of myocarditis per million dose were, in this age group, 1.34. And I think that the way they calculated expected is not the baseline risk of myocarditis, but what they did was they said a million, and I have asked Dr. Oster to give me some clarity on this one. I think what they did was, so I may be wrong, they said a million doses are probably going to be given to, let's say, 600,000 or 7. Some would get 1 dose and some will get 2 doses. And then if you take that number of children, let's say 500,000 or 700,000, and then you observe them for a given period of time, in this case, December to August, and see how many of them will become infected or how many of them naturally will develop myocarditis. That is their expected rate. This is how they, I think, calculate it. But as I learn more, I'll let you know. So 1.34 was expected. 105.86 was the reality with the second dose. So almost 80 times higher, 70 to 80 times higher. So that was 16 to 17. If you look at the third row, that is 18 to 24, and you would notice this trend that as the age is increasing, the myocarditis incidence or risk is reducing. Risk because of the vaccine is reducing. So the third row, 18 to 24, 1.76 per million doses were expected. What did they actually find? The second dose, 52.43. So almost 25 or 29, 30 times higher. And you can then do the math for the rest as well. For example, if I go to 50 to 64, 0.77 per million doses and 0.68 after the second dose. So almost same or lower. And you might look at the 65 and over, that data is not present. The reason for that is that they said we did not have good data in 2017 to 2019 timeframe, so they just did not use the data for this group. I still am confused about the number of doses. Did they exclude? So when they counted 12 to 15 years of age and their doses and the myocarditis incidence, did they actually use the doses given to this group? Or they just accumulated all Moderna, for example, for this group, and then just use that as a divisor? I don't know that part. Okay, so this is males. And 82% of the incidence was in males' second dose. Females, lesser incidence. So if you see here, 12 to 15 years of age, expected was 0.17, actual was 6.35. So again, about 0.2 and 6.35. So what, 12, 5, 30 times or more? If you look at 16 to 17, 0.42 was expected, 10.98. So almost 20, 21, 22 times or more, and so on. So the actual incidence observed while underreported was still higher than expected. And this data has been out there since January. Do you want to see how CDC looked at this data? It is actually interesting to see what did they do about it. Here is what they did. They said, so this is November 12. So this study was published in January 2022, I believe. So if I go back here, January 25, 2022. CDC had this data or this kind of data in November. And they said, what do you want? What do you need to know? Cases of myocarditis reported to the vaccine adverse VAERS after mRNA COVID vaccine, Pfizer or Moderna, especially in male adolescent and young adults, more often after the second dose, usually within a week of the vaccination. This is exactly the same thing as in this study. Most patients with myocarditis or pericarditis who received care responded well to medicine and rest and felt better quickly. Patient can usually return to their normal activity with their symptoms improve. They may have been diagnosed with myocarditis, should consult with their cardiologist if they are, heart doctor about return to exercises or sports. I kind of am interested in seeing that those who did not have insurances, what was the follow-up for them. Both myocarditis and pericarditis had the following symptoms, and then they give the symptoms. This is almost a summary of that study. Then they say, should I still get myself or my child vaccinated? Yes. CDC continues to recommend that everyone age 5 years and older get vaccinated for COVID-19. The known risk of COVID-19 illness and its related. So you know what they're saying here. It's not something that I need to read it. So they're I think they have absorbed this data. They have even given you the summary, and then they said, yeah, sure, keep going. Now, clinical course. What happened to these patients and what was the progression? So, majority in the younger patient, 30 years and younger, chest pain, pressure, and discomfort, chest discomfort. These are classic signs of myocarditis. You feel there is something on the chest, and there is a feeling of binding in here. So discomfort, pressure, chest pain, 89%. Dyspnea or shortness of breath. And dyspnea or shortness of breath would occur when heart is not able to pump correctly because it is injured. Just imagine if you have an injury on your hand. Would you be able to operate correctly? Now imagine heart. Heart doesn't have the luxury of taking a rest. It cannot rest. It has to continue to work till we die. So injured or not, it has to work. So what happens is its functionality reduces, its output, its work reduces. So when heart cannot pump blood correctly, that is when we can feel shortness of breath because of lack of oxygen and nutrition. Plus, if heart does not pump blood correctly, sometimes that causes the blood to start, or the fluids to start accumulating in the lungs, depending upon which side of the heart is failing, and that causes the shortness of breath as well. So dyspnea or shortness of breath. Troponin level increase. So troponin is the within the heart. Of course, heart is a muscle. So if I can quickly draw this, heart is a branched muscle. So let's say this is a heart muscle. Within the heart muscle, there are muscle fibers called myosin, and then there are muscle fibers called actin. And these guys, actin and myosin, they connect with each other, and they're like actin walks on myosin to contract a muscle. This is not correct, the diagram, but anyways, they help the muscle contract or relax. This actin fiber in turn has proteins on it which are called troponin, and there are multiple type of troponins. But anyways, imagine these are little proteins that are inside the cell. When the damage occurs and the cell breaks, like an egg breaks and opens up, just like when you're frying an egg and you kind of open it up. When the egg breaks, then the things inside the egg or this cell, they will be leaked out. And where would they go? They'll go in the blood. So now, excuse me, my apologies. So now inside this blood, you could actually measure the troponin levels. And so that actually is an indicator of cardiac muscle fiber getting enough damage that they have broken open. This could be a problem in the long run. Just like if I have an injury on my hand, and if the injury is deep enough, I might get scar, I might get a problem for the rest of my life because there's a scar there. Heart could also end up be enough damaged that there is, let's say, a part of the heart that is now scarred. So let's say this is the chambers of the heart. I have just picked up one piece of it, and let's say here. So if there is a damage in this area has become kind of scooped out because of the damage here, then this part has become thin. And as with age, as there is continuous pumping of the heart, this thing can start ballooning outward under pressure, and that can at some point fail. So this is what happens to many of us who would in older age get heart attacks and then end up with this. Then wherever there is a scar tissue, that scar tissue does not function with the rest of the heart. So now the heart fibers are contracting, but that part of the scar tissue does not contract very well. Then Wherever there is a scar tissue, there is a possibility of irritation in that area, and that can become a ectopic focus. It can start creating beats for the heart. Similarly, the signal that is passing, electrical signal that is going through the heart, when it comes around this kind of a damaged area, it can actually try to bypass this, and in that process it can become a circular uh, impulse which just keeps going backward, forward, and just keeps getting trapped over here, causing arrhythmias. So there can be long-term outcomes, but that really depends upon figuring out the labs and the echo and the MRI to see exactly what happened. This is why I said those who do not have insurance and got vaccinated and ended up with this, what is the recourse for them? Those who are insured, at least they can go and figure out how much is the damage. The immediate damage may not be as much, but maybe long term, there is going to be an effect. So the troponin, going back to the troponin discussion, and again, I will remind you, so I'm not said that I'm fear mongering. This would happen with the baseline myocarditis that can happen in children. This would happen. This is the same thing that would happen if there is myocarditis because of COVID. And this is the same thing that would happen if there is myocarditis because of vaccine. An interesting thing they said in the article, in the study, they said myocarditis that developed after the vaccine developed faster and resolved faster compared to myocarditis that develops with infection or otherwise. So that was an interesting difference. Now back here, troponin levels, that is indicator of cardiac damage, abnormal EKG. So electrocardiogram, that was abnormal. So normally we have the atrial impulse, and then we have the ventricular contraction, then we have ventricular repolarization. So this EKG can become abnormal if there is a ventricular wall damage. And the abnormality, there are tons of type of abnormalities, then it depends upon which EKG lead you're looking at, but it is possible that there is, for example, an elevated ST segment, or it is possible that there is I'm just really drawing this, there is a depression in the ST segment, and many more. So there were some patients who had abnormal EKG. Now, these numbers, for example, excuse me, for example, 72% here. This is not 72% of all. They had EKG done on a smaller number of patients, I think about 250 or 30. And this is out of those. So whatever test they're talking about, it is out of the people who were tested for that, and they have given those numbers in the study. MRI was abnormal for those who had the MRI. I think about 800 were done with the MRI. Out of them, 72% had abnormal MRI. So there was abnormality in the heart. There was damage to the heart that could be seen. Then echo. Echo looks at the cardiac flow and dynamics of the fluid in the heart, and 12% of the patients had abnormal echo where the ejection fraction was lesser than 50. And what does that mean? Every cardiac beat, when we have, let's say, if we all watch for our heart, it is beating, correct? So what happens is, in the beginning, the heart kind of relaxes and lets the fluids, blood, come in its cavity and fill the cavity. So this is diastole. Diastole is when the heart is relaxed and blood is filling in its cavity freely. Once the diastole is finished and the heart has this amount of blood in it, then what happens is the heart goes in a systole or in a contraction. When the contraction occurs, and let's say the cardiac cavity reduces in size as a result of contraction, the extra blood that was present in there, that blood will be ejected. And that will go in the aorta from the left ventricle and then to the body. The ejection fraction is the percentage of blood volume that got out from the existing total volume. So normally 50 to 75% is the ejection fraction. That means almost half of the blood in the heart is pushed out with a beat. I'm talking about left ventricle. They saw that in some cases, this ejection fraction dropped below 50. Normally, even 40 to 50 is called borderline okay. But this is, as they termed it, they said notable change in ejection fraction, or notable change in echo was seen. Then what were the treatments? And they actually have a complete list of the treatments that were given. I'm just going to highlight some of this. So if you go down here, you can see chest pain. These are the symptoms, and here is the treatment: NSAIDs, glucocorticoids or steroids, anticoagulants, antiarrhythmic, lower high-level nasal cannula, diuretics, intravenous. So if we wanted at some point, I can go over these treatments. We are already 41 minutes into it. So the treatment is, so NSAIDs, non-steroidal anti-inflammatory drugs, because there is inflammation going on, there is damage going on. So the 87% got that. Intravenous immunoglobulins and steroids, 12%. Vasoactive medication, 12 cases, not percent, 12 cases. Ventilation, 2 cases. In 87% of the patients who discharged. So by the time the study was written, out of all the cases of myocarditis, 1990 something, out of which 1600 were confirmed, out of all of those cases, the ones that ended up in the hospital, I think about 90% were discharged. Now, of those that were discharged, 87% had resolution of their symptoms at the time of discharge. That means what? That means there were some that were still in the hospital. There were some that were going from the hospital, but they still had symptoms. They were not fully resolved. And then the authors say, at the time of data review, there were 2 reports of death in persons younger than 30 years of age with potential myocarditis that remain under investigation and are not included in the case count. So absolutely. So Selfla says that cardiologist says do not engage in exercise for 6 months and reevaluate. Absolutely. There's a cardiac damage and we only have one heart. So this is the discussion. Just a quick look on the rest of the paper. Good paper, but I think comorbidities and the denominator for various calculations is not clear to me. This is the limitations. It would be good if you can look at the limitations too. I presented a couple of them, where's and the other. Then they do present how did they calculate the expected rates. That was IBM's data that they used, and the conclusion is something that we've already seen. So this is the discussion. Thank you very much for your time. Do me a favor, in the description, there is a link, description of this video. There is a link that offers you access to about 1,000 videos on drbeen.com, which are by me and other doctors as well. Premium content, and the price is so low that probably a couple of lunches would cover that price, and that is one-time price. So take advantage of that. In addition to this, if you would like to support this work, I try to keep my work as unbiased, as non-fear-mongering as possible. If you would like to support this work, there are links in the description. You can buy me a coffee, or you can use PayPal, or you can be a patron. So thank you very much, and I would see you shortly. And of course, please like, subscribe, and share.